Welcome back, everybody. How's the sound? Have I finally got this mute unmute thing down? Well, once again, I am Jenny Williamson, the Executive Director of the C3 Foundation. On behalf of myself and our founder and CEO, Claudia Christian, we are so glad that you are here watching our second annual virtual TSM conference, Stronger Than Your Drink. Please feel free to use the chat function if you're watching live on Twitch and ask questions all throughout the panel. I'll do my best to answer any questions you've got. This conference is available to view and participate in for free, thanks to our two co-headline sponsors, RIA Health and Work It Health. If you'd like to support the work of the C3 Foundation, there's a donate link in our profile, and we also have a timer that is dropping the donation link into the chat during the broadcast. And if you're on Twitter, please feel free to live tweet our conference with the hashtags Stronger Than Your Drink and Options Save Lives. It's a great way to amplify the impact and reach of our conference. Next up, we have Dr. Clifford Fields and James Kamanski. Lead presenter Dr. Clifford Fields is a physician working with Alcure, treating Sinclair Method patients. Dr. Fields has over 30 years of experience and specializes in emergency medicine and family practice. And he also has a background in treating patients facing substance abuse challenges, including working with patients struggling with opioid addiction. Dr. Fields earned his medical degree in 1985 at the University of Health Sciences College of Osteopathic Medicine in Missouri. He also served as a general medical officer and squadron medical officer with the U.S. Navy. Co-presenter Jim Kamanski is a California licensed attorney and co-founder of the Alcure digital health platform, which focuses exclusively on offering the Sinclair Method to patients through telehealth in multiple states. Jim has been peer nominated as a Southern California super lawyer for 10 consecutive years and has over 25 years of experience practicing an area of law requiring an extensive knowledge of medicine. So because Dr. Fields is on call this weekend, that's the emergency management part of his career, but he really wanted to participate in our conference. We recorded this in advance because he's going to talk about the side effects of naltrexone, which is a very popular, concerning topic for many. So I'm going to go ahead and cut right to the recording.
Hello, everybody. Jim Kamanski, co-founder of Alcure with Novia. We've got Dr. Clifford Fields in the house working on the Alcure telehealth platform, offering the Sinclair Method completely online in 17 states and looking to expand. And Dr. Fields is in 17 states. He's covering a broad part of the East Coast, part of the central United States, and he's come as far west as Nevada. Dr. Fields is board eligible in addiction medicine and board certified in emergency medicine and family medicine. He currently practices emergency medicine and addiction medicine, and his focus is the treatment of people with opiate and alcohol use disorders. And we're going to be presenting on the side effects of naltrexone in Sinclair Method treatment. But before we get started, I wanted to ask Dr. Fields, if you could explain to us a little bit more about your background, tell us how long you've been practicing medicine, where you went to medical school, etc.
Sure, Jim. Thanks. It's good to see you. Briefly, went to medical school in Kansas City in the 80s on a military scholarship. I got graduated in 1985, did my general internship followed by my military obligation around the world as a general medical officer. And then when I finished that, I went back and did my residency training in both family medicine and emergency medicine. For the first 20 years, almost exclusively emergency medicine, some critical care. And then over the last 10 years, I've been splitting my practice between emergency medicine and addiction medicine. Initially started out treating folks with opiate use disorder, but over the last 5 or so years have expanded to include a lot of folks with alcohol use disorder, mainly on the Alcure platform. So it's my background in a nutshell.
Let me ask you briefly with these two broad subspecialties, the comparison between emergency medicine and addiction medicine in the office.
Right. They couldn't be more different. In emergency medicine, we're on the cutting edge of substance use disorder. We see all the problems, the serious problems that arise from it, from overdose, complications of alcohol use, patients with cirrhosis, pancreatitis, brain disease. A secret that what's commonly known to emergency physicians is most trauma that we see is substance use related, DUI, people falling. Usually there's substance use behind that. Why we see a lot of substance use disorder in the emergency room, the patients are brought in there mainly as a consequence of a complication of their substance use disorder, whereas in the office, people have come to terms, they understand they've got a substance use disorder, they're looking for treatment, and it's a much more positive experience where they're motivated and looking for help, and it's a pretty positive situation, positive experience.
And in terms of folks you've treated with the Sinclair Method, about how many have you had the opportunity to treat?
I'd say about 200, maybe a little more. 200 folks with alcohol use disorder, and the majority of them, almost all, with targeted dosing. That is the Sinclair Method.
Great, great. I appreciate that. All right, let's get into our slides then. Use of naltrexone in Sinclair Method. What are we talking about here?
Sure. So a little history. Naltrexone was put on the market in the 80s for substance use, for opiate use disorder, reasonably effective. In 1994, the company that brought it through the FDA presented it as an anti-craving medication. The dosing was 50 milligrams a day, and the main purpose was to decrease craving for alcohol. The goal in those days was always complete abstinence. Any alcohol consumption was considered a failure of treatment. Come ahead about 10 years, and Dr. Sinclair thought that the drug was a little more complicated, that it wasn't just an anti-craving medication, that endorphins were integral to the development of alcohol use disorder, and by blocking the alcohol-induced release of endorphins, he believed that would lead to decreased importance of alcohol, a change in the brain structure and function, and eventually to the elimination or extinction of alcohol use disorder. He did two things. He changed the dosing from once daily to only prior to drinking alcohol, so 1 to 2 hours prior to drinking alcohol. That was the only time that he thought the medication was effective, when it was paired with alcohol. And he also moved the goalposts. So prior to 2004, the idea in medicine that you could drink alcohol, you could have alcohol use disorder and drink alcohol was an anathema. He said that, or he came up with, if we moved folks from unsafe, unhealthy levels of alcohol use to safe levels, no more than 2 drinks per day in a male, 1 per day in a female, and along with a few other metrics, that would count as success. So he came up with targeted dosing, and instead of complete abstinence, safe levels of drinking was a perfectly reasonable goal.
Let me ask you one question about what you said. You'd use the word extinction, and my understanding is that's sort of a version of unlearning something. but at a more root level of the body, sort of subconscious. Because when I think of the word learning, which I've seen used in the Sinclair Method literature about how you can acquire an alcohol use disorder, I think about learning the piano or learning a language. It's a different kind of learning, though, right?
Yeah, it sure is. It's complex neurobiology. To say we understand it completely would not be accurate. What we do know is that while alcohol causes stimulation of many receptors in the brain, GABA receptors being the most important, the stimulation of the endorphin receptors or the opioid receptors leads to the learning in a subconscious way of alcohol use disorder and leads to structural and functional brain changes. His idea was that if you blocked the endorphins, those functional and structural brain changes will diminish over time.
All right, gotcha. Great. Let's get into the next slide. How naltrexone works. Tell us what's happening here.
Sure. So naltrexone is an opiate receptor antagonist or blocker. Simply put, the alcohol-induced release of endorphins leads to the alcohol use disorder and is an important part of the development of alcohol use disorder and the subsequent brain changes that go along with it. If we can block the effect, if we can block the endorphins from working, we can then push back, unlearn, lead to the extinction of alcohol use disorder. So naltrexone is a simple medication. It is a opioid receptor blocker.
And the opioid receptor, just so I can reflect back, the receptor is something that sits on the neuron in the brain and other parts of the body, right?
Correct.
Okay. And if it blocks endorphins and opiates, is because endorphins are similar to opiates in a way?
Absolutely. Yes. Endorphins are named after endogenous morphine. They are, the reason opiates work is that they look like endorphins and they can fit in endorphin receptors.
I got you. Great. Thank you. Let's go to the next slide here. How naltrexone causes side effects, getting into the heart of the topic. Tell us what's happening here.
So it would be great if naltrexone would only go to the parts of the brain and the parts of the body that are involved in alcohol use disorder. The two big targets these days in addiction research are the VTA, ventral tegmental area, and the nucleus accumbens. Nucleus accumbens are the frontal cortex. If naltrexone could just go there and do its job, it probably wouldn't have any side effects. But naltrexone will go to wherever there are endorphin receptors, and they're present throughout the brain. They're overrepresented in the GI system. They're present in the musculoskeletal system. So it stands to reason that if you block receptors in these other regions, side effects can occur.
I see. Now at the bottom of this slide, it says in capital letters, most people do fine. What are we talking about here?
Right. So while we have a good explanation for why naltrexone can cause GI side effects and musculoskeletal side effects and brain side effects, most people have no side effects from the medication. Those people who do have side effects, they're self-limited to go away over a short period of time. And those who have the more moderate to severe side effects, we can usually work through them. So while this talk is an important one on the side effects, most people out there using the Sinclair method have never seen a side effect.
That sounds reassuring to me. If I were a patient and I were coming to the Sinclair method and I hadn't heard much about it and I was concerned with my alcohol use disorder, you're saying that you would be telling me as a new patient, look, you probably have a very good chance of not having any side effects, or if you do, minimal. Fair to say?
Fair to say, but I always spend a good 10 minutes on the first visit going through the potential side effects.
I gotcha. Okay,
Yeah.
let's get into the next slide. Common side effects of naltrexone. Tell us what's happening here.
Right. So the GI tract has a fair amount of endorphin receptors throughout the entire GI tract, and it stands to reason that if you block those receptors, something's going to happen, or something can happen. So the main effect of endorphins on the GI tract is to slow it down. It's for to make sense of it. If you're involved in a high endorphin activity, such as a sporting event, you want your GI tract shut down. So the endorphins are a natural brake on the GI system. If you go ahead and remove the brakes, it makes sense that nausea and vomiting, nausea less so vomiting, stomach cramps and diarrhea can develop. Same thing in the brain. It's not just the parts of the brain that are involved in substance use disorder that have endorphin tracts in them. Parts of the brain that are responsible for controlling pain, promoting calmness, allowing sleep, have endorphin as an important neurotransmitter in their tracts. And if you block the effect of endorphins, you can expect some side effects. Headache being the most common, sleep disturbance the next, less likely, but more disturbing, anxiety and dizziness. So
I see at the bottom of under brain, and we'll get to musculoskeletal in a moment, we've got in italics opiate withdrawal. What is that all about?
sure. So they're very there's only two rules, absolute rules in my practice of the Sinclair method. Number one is whenever you drink alcohol, you must have pre-treated yourself with naltrexone. End of story. You can't get away from that. And the other is you can't take naltrexone if you take opiates. If you take opiates on a regular basis for chronic pain, taking naltrexone will cause the displacement of those opiate receptors displacement of the opiates, oxycodone, morphine, hydrocodone, etc., and puts you into medically precipitated withdrawal. It's a violent, ugly experience that you don't want to go through. And so the one absolute contraindication to the use of naltrexone is regular use of opioids for whatever reason.
And is it fair to say that there are some people out there that are living normal lives, but they do have to take opioids that are prescribed to them for something like chronic back pain or what have you?
Correct, absolutely. I've had I've had two folks in the last few months who, when we first checked in, they were taking a drug that they thought wasn't an opiate, tramadol. Tramadol was marketed as a non-opiate, but it is an opiate. And we made a plan. They thought their alcohol use disorder was more significant than their chronic pain or the benefit they received from their tramadol. So over 2 months, they went off of the medication and they were able to then start naltrexone and had good effect for their alcohol use disorder.
Great, great. Tell us about musculoskeletal.
I put that up there because there are receptors, opiate receptors on the muscles and joints, and a reasonably common side effect is muscle aches and pains, kind of flu-like symptoms. And so patients taking naltrexone for the first couple of days can end up with muscle aches and joint pain.
Gotcha. Okay, let's get into the next slide. Addressing side effects of naltrexone. Tell us what's happening here.
Yeah, so while this topic's important, most people don't get side effects. Those who do have side effects, the symptoms are mild. And if they're forewarned about it, if they understand that these side effects may be coming, they're going to be mild to moderate and they will go away with time, they can quite often deal with it. Overarching approach to the treatment of side effects is that if the side effects don't resolve quickly, or if they're severe and they're a little too tough to deal with, we then go to decreasing the dose, allowing the body to acclimate to the medication, and then slowly bring the dose back up to a therapeutic level.
So it sounds to me, from looking at this slide and hearing your discussion, that globally for all side effects, the tool of the provider, the first two tools that come out are using time and decreasing dosage. Fair to say?
Yeah, and I would add warning folks ahead of time what to expect.
Okay. And that happens in your first, right off the bat, in your first video chat with the patient?
Absolutely. Absolutely.
Gotcha. All right, let's get into the next slide. Again, addressing side effects of naltrexone. We have some more topics here. What's going on here?
Sure. In my experience, far and away, the most common side effect is nausea. Few folks end up with vomiting. And as I said, not to be redundant, but when clients expect this side effect and it comes along and they know it's going to pass in a few days, it's easy to deal with. If it doesn't just pass on its own, or it's a little disturbing, very simple, such as taking the medication. Again, it's always 1 to 2 hours prior to ingestion of alcohol, but taking it with some food or a little extra water to decrease the irritant effect on the stomach. There's a few folks who end up needing an anti-nausea medication for a week or two, but they're in the minority. And in
Let me ask you real quick, what would be the anti-nausea medications that you would go to?
For whatever a physician wanted to prescribe would be fine. I tend to go with ondansetron or Zofran these days. In the emergency department, it's our drug of choice, and I'm very comfortable with it. So and they make a sublingual form that dissolves. But with that said, out of 200 people, 5 prescriptions maybe, if so.
Okay. And then diarrhea, never pleasant.
Yeah. Well, the diarrhea makes perfect sense. So the GI tract is lined with opiate receptors. And again, endorphins or opiates put a brake on the GI tract. And naltrexone would take that brake off. So diarrhea is a perfectly explainable side effect based on the mechanism of action. There's actually a fascinating drug. One company there are a lot of people who take opiates for good reasons who end up with constipation because the opiates stimulate the endorphin receptors and lead to constipation. You see it on TV all the time, the opiate-induced constipation. But a company took naltrexone, modified it to methyl naltrexone. And methyl naltrexone can't get into the brain, so the opiates are still going to go into the brain and do their job. But it works in the GI tract, and it relieves constipation within 30 minutes to an hour or two.
Is that the loperamide?
No, that one cost a fortune. Methyl naltrexone. Loperamide's over the counter, and it's got a different structure, but it works by blocking. So loperamide works by blocking the opioid receptors in the gut, just as opiates would. So it's an agonist rather than an antagonist. And it will act like an endorphin and put brakes on the GI tract. So to make sense that naltrexone would block the opiate receptors, loperamide would stimulate the opiate receptors.
I've got two observations in on this, and we've got the word Imodium next to loperamide. Imodium is something I've always seen whenever I go to the drugstore or the supermarket, and then I see above that we've got simple measures. Is it fair to say that when we're dealing with side effects, that we're usually doing pretty simple stuff by forewarning the patient, using time, using the common sense approach of decreasing the dosage, and then escalating up to now more simple measures?
Correct. Well summarized. And loperamide is still a pretty safe, simple intervention.
Okay. And then the other question I had was, when you are forewarning the patient during the initial eval of what they may expect, which you're telling us gives a much better result for the patient when it does come, side effects do come, that what's the normal turnaround time? Let's presume I'm a patient. You and I have had the initial video conference. I'm all ready to go. I've taken my GoodRx coupon down. I've got my Naltrexone, and I have my first drinking session, and I have headache and upset stomach. About how fast do you hear back from me?
So actually, the point I want to make is that, to me, the worst side effect of this medication would be to give up on it quickly because of whatever reason. There's nothing better out there for alcohol use disorder. So nothing bothers me more in this practice than if someone takes the medicine, has a side effect, and stops taking the medication. So I tell them right off the bat, please, if you have anything disturbing to you that's going to prevent you from using this medication, get right back to me. So most of my folks, the side effects are usually immediate. They'll wait a second dose to see if it goes away. So it's usually after the second dose that I have the folks with side effects to get back to me. I want to work through it because there's not much we have that works this well for alcohol use disorder.
Right. So jumping on it, basically telling them, look, I want to jump on this thing early because we want to get you through this because the benefits could be really good. That's what I'm taking away from that. All right, let's jump into the next slide here. Again, addressing side effects of naltrexone, still a more common headache. Tell us a little bit more about this.
Right. So as we mentioned previously, there are other tracts in the brain that use endorphins, and some of the analgesic pathways, the pain control pathways, involve endorphins. And I'd say the second most common side effect in my practice, although it's a minor side effect, is a headache the first few days after taking the medication. Rare that it's a bad enough headache to bring to my attention, even more rare for it to be bad enough to stop taking the medication. And I recommend to these folks that if it's bothersome, take some acetaminophen, which is my preference, or ibuprofen if that's what they'd like. And it's usually a done deal with that.
We've got written next to acetaminophen Tylenol, another one we see everywhere, TV, supermarket, drugstore, and then Motrin we'll talk about in a minute. My understanding, if I'm coming from a patient's perspective, is that alcohol is always a little bit of a challenge on the liver, and that Tylenol, generally speaking, is something you don't want to be taking too much of because it can challenge the liver as well. Wouldn't doubling up on Tylenol and consuming alcohol at the same time be possibly a hazard?
That's a good point and a common misunderstanding. Acetaminophen at therapeutic doses is not a liver toxin. So if your liver is working and you don't have severe cirrhosis, a therapeutic dose of Tylenol or acetaminophen is not going to cause liver damage. Acetaminophen is a liver toxin in overdose or chronically taken at high levels. So someone without known liver disease can take 4 grams a day. someone with mild liver disease, and most of our folks with alcohol use disorder do not have liver disease. But even folks with liver disease can take up to 3 grams a day. So recommending someone to take 2 regular strength or 2 extra strength Tylenol now and again, I think is very safe.
Okay, so to put that into context, then in my medicine cabinet, I have the extra strength pills, and they're 500 milligrams, and so 2 of those would equal 1 gram. And you had mentioned 4 grams is sort of the outside limit. So we'd really be taking a lot of pills of Tylenol before we got into danger, right?
Correct.
Okay.
Correct.
All right. So 1 or 2 of those should be no problem. What about ibuprofen?
So ibuprofen's a great drug. When I started practice, it was by prescription only, and now it's over the counter. It's a fantastic medication for pain and for fever, but unlike acetaminophen, which in therapeutic doses, acetaminophen in therapeutic doses is non-toxic, ibuprofen can be toxic with a single dose or several doses. So most people, it's fine. But there are cardiologists who will not allow their patients with heart disease to take it because it can lead to a heart attack. If you have some irritation in your stomach from alcohol, let's say, ibuprofen can make the stomach irritation worse. Can take gastritis and turn it into severe gastritis or cause bleeding. And as crazy as it seems, it's as little as 1 dose of a non-steroidal anti-inflammatory, which ibuprofen is one, has been known to cause kidney injury, and enough to require treatment in a hospital. So I don't want to be about ibuprofen. It's a good medication, but nothing's as safe as acetaminophen out there for the treatment of pain.
So that's the takeaway on this one is the big picture on this slide sounds to me that if you do have a headache and you can't tolerate it just by putting up with it for a little bit, then the go-to over-the-counter medication would be Tylenol, by far and away your preference.
Right, a dose here and there.
Gotcha. And then just a quick footnote, since we were talking about the liver, what's your take on some of the earlier literature? My understanding was that you would want to presumptively do a liver function test before prescribing any little bit of naltrexone. What's the modern view or your view on that?
Oh, that's a great question. So I think there were some case reports back in the day that some studious physicians noted that some patients taking naltrexone had some liver problems. And the drug company, when they put out the product, said, let's be safe. Let's not give it to folks who have liver problems, and it might cause liver problems. Subsequent studies reviewed by the Food and Drug Administration no longer classified naltrexone as a liver toxin. They now classify it as a possible but unlikely liver toxin. And their practical recommendations are that when you get to a dose of 250 milligrams per day of naltrexone, that's a reasonable point to start looking at liver function tests. With that said, if someone develops signs of liver disease while taking naltrexone, you should check the liver function test. But as a rule, if someone has no signs of liver disease, I do not measure the liver function test at all.
2 questions there. Then I think that's something we screen for in the initial questionnaire at Alcure, right? Is if you have any signs or symptoms of liver function, right?
Yeah, if you have, it's like any. We're not a kiosk where someone's asking for naltrexone, and sure, here it is. I do a thorough evaluation and want to know about everybody's every medical condition and every medication someone's taking, and we do want to know that if they have underlying liver disease. I've got a couple of folks right now that have a liver disease, hemochromatosis, I believe. And we, because that disease can affect the liver, we watch the liver function test. But being comprehensive is important in treating folks with this type of medical condition.
Gotcha. And then the last little point on this slide before we jump into the next one is you had mentioned 250 milligrams was documented in the literature as sort of an outside area where you might be getting into that issue. For Sinclair method treatment, the default to start with is 50 milligrams of naltrexone prior to drinking and take it another time, right?
Correct.
But in your practice, you've tinkered it upwards a couple times to get better traction, right?
Right. There's some. The drug is safe. It's probably safer and higher than 250, but that's where the FDA is saying, "Hey, let's pick a number and do testing." In my practice and in reviewing the current literature, if someone doesn't have a response to 50 milligrams, some articles out there saying go to 100 milligrams and then 150. And that's what I do personally. If someone's not getting an effect at 50, within a month or two, go to 75 and then 100. And quite a few people who, 100 is their number, not 50. So.
Gotcha. That's good. There's that flexibility too. All right, let's move on to the next slide. Still on addressing side effects of naltrexone, less common now. Tell us what's happening here.
Sure. From those receptors being blocked on the muscles in the joint and the brain, a handful of people will get muscle aches, flu-like symptoms. Nothing that's going to last a few days, perhaps a little longer, but a self-limited problem. So just a little warning that if you feel achy the first day, don't worry about it. That's expected. Endorphins promote sleep. A lot of folks with alcohol use disorder drink to facilitate sleep. And so if you go ahead and remove the endorphins effect on the brain, it's reasonable to expect insomnia or vivid dreams for the first few nights. We see it, not too common, but when it happens, it's disturbing to the patient. Other effects, so flu-like symptoms, Tylenol and Motrin, sleep disturbance. Most folks, it was a rough night or two, but it's over. Folks who need to catch up on their sleep, and over-the-counter sleep agent, diphenhydramine. The symptoms that bother me the most as a physician are when patients develop anxiety and dizziness, really disturbing anxiety and dizziness. The literature out there about people not being able to tolerate naltrexone, that the numbers are thrown around as 5 to 10% of people have trouble taking the medication and end up stopping it. And I think it's because of the side effect of anxiety and dizziness, kind of a withdrawal type effect. As I said, that's the one that bothers me the most because people often walk away from the medication at that time. So I warn the folks ahead of time. You may feel it. If you do, please let me know right away. You can stop the medicine for the short term if it's disturbing, but we can work our way through it. And then the last bullet point I have, any side effects that come up, it's worth discussing with your physician. While it's safe, everybody's unique and you may have different side effects than other folks. Recent reviews show there have not been any life-threatening reactions to the medication. That's good, it's safe. And there's been a few case reports of people taking the long-acting version of it.
Is that the Vivitrol, the injection?
Right. People taking that and developing suicidal ideation. It's not a clear-cut association, but if it happens, we need to know about it right away and address it.
Okay.
Unlikely that it's related to the medication. I guess in the with the Vivitrol issue, it's a problem because you can't just take the medicine away. it's there for a month. So I guess they were arguing that before you give the long-acting agent, you should try the short-acting agent.
You had mentioned under sleep disturbances a medication, and I was trying to figure out what the trade name might be for that, if it's an over-the-counter medication.
Yeah. The trade names, yes. Yeah, the trade names have been beaten out of me. I'm supposed to use just the chemical names. Big
I always like to
pharma.
go back to because we're the ones, us non-doctors are the ones that are milling around the supermarket and the drugstore looking for things that are going to help us out. So just to reflect back on this, and we'll get into the next slide, which is a great topic, but it sounds to me that we start off with very early intervention from the provider perspective, very, very early intervention that starts with just a good piece of education, forewarning, and that takes out a lot of the sting, it would sound like. Makes sense in general.
Well put.
And then if there is a little sting from this, they can come right back to you. How do they get back to you, generally speaking? By email or video chat? Okay.
Emails, there's no barrier. The patient can contact me anytime and can get on my video chat platform. Usually it's an email that day. I'm sorry, day 2. Well, if it's the dizziness and anxiety, it's day 1. If it's the nausea or the headache, it's day 2 or day 3.
Okay.
By email.
Gotcha. And then in that situation, it's a stair-stepped, pretty straightforward intervention. I mean, it's going to be tailored to the particular symptoms they're presenting to you, but the general principles are, let's give it some time. We can play around with the dose reduction, and then we can add some over-the-counter medications and some other strategies. The question I had, though, was, even though these are pretty minimally invasive and do the trick, we're starting to mollify the whole treatment in particular, if you were to reduce the dosage, don't we go to like a subtherapeutic dosage, and then are we not defeating the whole purpose? How does that work out?
Well, that's a good question. And the one symptom that I quickly decreased the dose is anxiety and dizziness. That seems to be the most disturbing and present during the day. So the Sinclair Method treatment of alcohol use disorder with targeted dosing of Naltrexone is a process that to some degree, it's a lifelong process, but it's the usual target we look at is 6 months of treatment to get to a nice steady state. If we have to drop down to a subtherapeutic dose for a week or a month, that's not an issue. The goal is a long-term goal of getting to unlearning and extinction of the alcohol use disorder. That first few weeks or month where we're subtherapeutic, and we have to just titrate our dose back up, that's not a big price to pay for something that's going to have long-term benefit. So you're right. I had people down as low as 12.5 milligrams while they're adjusting, and it's unlikely that it's working at that dose, but that's okay. The goal is to get them to a therapeutic dose.
Okay, so one quick question. When you have them cut the pill, what do? Pull out the knife, bite it? Or
pill cut is the way to go.
Okay, I can get that at the supermarket or the drugstore too, right?
Correct.
All
Correct.
right. The okay, and then the other topic that I had on this was, well, let's just get into the next slide. Let's get into this one because I think this is a great topic. What's happening? Therapeutic alliance. What do we mean by this?
Right. So I think if you picked any disorder and treated it with have a kiosk dispense the medication versus a physician who knows you and can speak with you, and you can make decisions with that physician. I think the treatment, the disorder that you treat, whether it's hypertension, hypercholesterolemia, depression, alcohol use disorder, I think the treatment will work better if you have a teammate helping you through this. So, especially when it comes to side effects. So if you come up with, let's say the worst side effect in my mind, the anxiety. If you don't have a rapport with your physician who you can talk to and say, yes, this happens, and I think we can work our way through it, you're much more likely to get people through their side effects. You're much more likely to get them to target those if you're working as a team, if you're making shared decision making.
So it sounds to me that when we're talking about therapeutic alliance, and I've seen this in other medical literature, that this is a collaborative effort between provider and patient with Sinclair Method. It's different, for example, if I just have one encounter and I present with some symptoms and you say, look, take this medication, take it for 10 days, and call me if you have any problems. That's kind of a one-off situational encounter, whereas with Sinclair Method, we've got a process to go through, much easier process compared to other treatment models, which I want to ask you about in a minute, very briefly. But the longer the process is, especially when we have some side effects, you're saying that a very core relationship makes or breaks the difference in many cases? Are you there, Cliff?
Yes. Yes. Well, internet connection is unstable.
That's doing pretty good now. You're back.
Yeah. Yeah. So I think you were just saying, do patients do better when they have a relationship with a physician that they can bounce questions off? This, when you're involved in a process like the Sinclair Method, questions come up all the time, and there are good sources on the internet to get answers, but there's some bad sources as well, and to be able to speak with the folks who trust you and whom you have a good relationship with, you're likely to keep them on the correct path.
And then I wanted to go back to the whole idea of using potentially a subtherapeutic dose and some of these other things that maybe people don't want to always have to be taking, with the assurance that they're going to go away. We're going to go back up on a dosage to the 50, or in some cases, if you don't get traction, 75 or 100, you may have to take some Tylenol, even if you don't like to take medications, and some people don't like to take any OTCs, for a little bit. It sounds to me, and tell me if this is a fair assessment, this would be like a bridging technique or a stair-step technique to take the patient from zero, where they're not getting any treatment, to a full-blown, nice, steady Sinclair Method protocol. Fair to say?
Fair to say. And again, the worst side effect, the worst failure is, from my point of view, is to have a patient not have a chance at the full benefit of naltrexone. If they take the medicine, they get a side effect that's disturbing and they walk away, I consider that a personal failure. I want them to come back to me and say, I've got some problems with the medication, and we'll try to work it through. It's not like you're treating hypertension and you treat them with a beta blocker, and it interferes with their athletic ability, and you switch it to an ACE inhibitor or an ARB. In alcohol use disorder, there are two other drugs, but none that are comparable to naltrexone. So you've got to do your best to make it work.
I was going to ask you about that briefly. We had been chatting about this before our presentation, and I think you had mentioned that within the realm of treating alcohol use disorder, there's precious little out there, but the Sinclair method in a way represents that bright shining light on the hill. Fair to say?
Well put. Well put. The Sinclair method, right? And eventually the drug from Europe's got to come over. I mean, it's
Nalmefene.
But right. So there might be, maybe it's got less side effects, maybe not, but it's got the same mechanism of action. And interestingly, it gives further proof to the Sinclair method, and that drug was trialed using the Sinclair method protocol. It was trialed and approved by the European Drug Administration or Agency. So
the one thing about Nalmefene, though, is I think it's still on patent. So if it ever does make it over here, it's going to be pricey, probably.
Yep.
Which is one of the beauties of the Sinclair method, is that naltrexone is pretty darn cheap to get.
Right. It's not going to cause poverty as a side effect.
So the last question I had is very practical, which has to do with home remedies. There's one I've heard of, which is taking cotton balls and soaking them in rubbing alcohol to get rid of nausea.
Right.
Does that work? Tell us about that.
Yes, it works. There are some emergency rooms, one that I work at, where anybody who presents with nausea who can't be brought right back to be treated will be given a little aluminum packet with alcohol wipe, break it open, sniff it, and it's helpful. It's helpful. And so in the emergency department, I'm seeing folks with severe nausea, and it's helpful. My bet, I don't have proof. My bet is if you have mild nausea, it may even work better. But just a little inhalation of isopropyl alcohol is perfectly legit.
That's great, Dr. Fields. I really appreciate you going through all of this information for us and helping me summarize it and understand it. But there's going to be a little bit of Q&A after that, and I'm going to turn it over to the next slide on Q&A. These are all going to be put to you, and off we go.
Fair enough. Greetings.
Take myself off of mute. And okay, so Dr. Fields, you say you've treated about 200 people with TSM. So I've got two questions on that. One, what has been the success rate you've seen in your patients? And two, how many people have you seen walk away because of side effects?
Yeah, so great question. And as a scientist to some degree, I'd be quick to say that my impression of the success rate is not the same as a trial that was done at a university with other folks not involved in treatment assessing benefit. So, and I look forward to, and actually, maybe the Nalmefene data would be considered more scientific. But I think the numbers that Dr. Sinclair came up with, 75 to 80% of the folks stay with it and have success. I would say the definition of success can be a little contentious. I have some folks who've gone from 20 drinks a day to 4, and they consider it success. In the trial, that would have been a failure. So depending on, so I think the numbers are the same, 75 to 80%. five to, so I think the numbers were higher when I first started years ago. I think maybe 1 out of 10 people would walk away saying the drug just made me feel horrible. And I didn't understand what they were talking about. And from learning from my patients over the years and what literature's come out, I think when they said they felt horrible, it was just a horrible anxiety and dizziness. So now on my intake, I give them the same numbers here. It's like, yeah, most folks aren't going to notice any side effects. Those who do, it's going to be mild. And if you have the disturbing ones, please get back to me and try to work you through it. So I think maybe we get it down to 5% of people, but that's just a gestalt.
Okay. And have you come across anyone who is not necessarily sensitive to the naltrexone, but the fillers in it? For instance, gluten is a common filler in many capsules. Have you had anyone come through with more of a filler issue where they've gone to a compound pharmacy and had it reformulated for them and had better results?
I haven't, but it sounds reasonable that may have been something very disturbing to folks, and they've backed off because of GI side effects. Is there? I don't know how many companies are making the medication. Is there just one out there?
Because it's generic, there are multiple out there, and
because I've had a few folks when when they've gone to their pharmacy to pick up the medication, they've received a different form of it, and I've had this with other disorders as well, where they found that they were intolerant to it, so that they would speak with their pharmacist and make sure that they got the initial generic that they were tolerant of.
Okay.
So,
and also, does it come up often that people are mistaking symptoms of alcohol withdrawal because of getting a big reaction on those first few drinking sessions on naltrexone, where they have reduced a lot, and mistaking those alcohol withdrawal symptoms for side effects?
Yes. Most people who are big drinkers and are going to go through withdrawal don't go from 90 miles an hour to 0 and go through over withdrawal. They're going from 90 miles an hour down to 60, and they can have withdrawal just from decreasing the amount. So yes, sorting the two out is very challenging. In the emergency department, it's a very easy thing to sort out. If someone took naltrexone and went from, just making up a number, 20 drinks on day 1 to 10 on day 2, and they're feeling horrible, and they don't know if it's the decrease in alcohol or the side effect, giving them some Valium type medication, if that resolves the symptoms completely, I think it's more likely alcohol withdrawal. But I think most of the folks are not drinking high enough levels and have an abrupt change to go through overt withdrawal. I think subtle withdrawal, where they have sleep disturbance from not drinking, they've been drinking 2 or 3 drinks before bed to get to sleep, and now they're not doing that. That's going to cause a sleep disturbance.
And then finally, when you're doing your screening, how often do you come across people who are disclosing additional supplements? Because as we know, Different supplements can have different properties, including one that we see in the peer support groups a lot is people will ask about things like kratom, which has been potentially linked by the FDA as having opiate-like properties. Do you coach your new patients about being aware of what supplements they're taking as well, so that those are not either exacerbating or competing against naltrexone?
Yes. So as part of the more and more these days, when you ask someone what medicines they're taking, they'll tell you which supplements. It's become more commonplace. I specifically, in the social history, ask about the more significant ones, such as kratom, and actually some. I don't consider kratom a supplement. I'm afraid of kratom. I consider it an opiate, and I consider it an opiate, and I think if you take naltrexone with kratom, it could be a bad day. So I'm not sure I answered your whole question.
Well, I think you got to the point of it, in that that it's important that that people disclose what supplements that they're taking, because not all of them are going to play nice with naltrexone.
Correct. Yeah, the good news these days is we're in my medical database and in the big hospital systems I work at. If you type in that someone's taken a supplement such as turmeric or some vitamin, it populates right in there and stays in their medication list. So we're starting to, instead of just ignoring it as physicians, it's entering onto our database and allowing us to make observations and share the patient's observation regarding potential interactions.
Well, that's excellent to hear. So I do want to thank you, gentlemen, for being a part of our second annual TSM virtual conference titled Stronger Than Your Drink.
I like it.
So as a parting thought, how does dealing with the side effects of the Sinclair Method make someone stronger than their drink?
You're welcome to add in, Jim.
Okay.
I would say, yeah. I've been a doctor forever. I've forgotten what it's like not to be one. And working with a patient or a client to work through some of either the mild or the severe side effects, you feel that they feel more tied to the treatment. They feel like they've earned this treatment, and it's kind of a growing experience. It's always enjoyable to work through a problem and just to feel the satisfaction after working through it.
As a corollary to that, my thought is that going back to the therapeutic alliance point that we were making, or you were making, Cliff, that what I've seen in my background as an attorney in bodily injury and deposing doctors and reviewing thousands of medical records over the years, that you're going to get a lot better outcome having that core traditional, call it old school, doctor-patient relationship, where the patient who's a little nervous about what's going on here, a little uncertain about what's going on here, can fall back on that physician, where that trust is so important. And then knowing that you have their back and that this stuff, and allaying their concerns allows them to tiptoe in a way from the shallow end a little bit more to the deeper end, and then pretty soon they can tread water fine, and they're off to the races with Sinclair Method, and their outcomes come out good. So I'm looking at it from the perspective the patient may be a little concerned and needs some reassurance, and that's the best remedy for that is that good, solid doctor-patient relationship.
Yeah, success with the Sinclair method makes the patient stronger to not be beholden to alcohol, to go out and do what you want without being encumbered by it. It's fantastic to watch.
All right. Thank you to our presenting sponsors, Work It Health and RIA Health, for making this conference possible. And thank you to Dr. Fields and Jim Kamanski for that talk about side effects. I know I learned a lot, so I hope that you guys did too. So we're going to go ahead and take a lunch break, and we'll be back for our next panel at 2 p.m. Eastern with Dr. Daniel Butler. Thanks, guys.